Good morning, everyone. All right. I'm in my office at Calvin, and the sun is going to make it a clear. Might have to move it. All right. Can you guys hear me first off? Sometimes my computer you can hear me. Okay. All right, great. All right. So today we're going over the final exam review. I did just post it on D2L a little bit ago. Um, our goal today is going to be to kind of go over all of the content that I think you guys should be focusing on to be successful for the final. And then I want to be able to answer any questions you may have specifically about maybe what to study, what to avoid. Well, I don't know that what to avoid is a good way to put it, but like what to spend the most of your time on versus not, and answer any questions that you might have. Okay. So I will start by sharing my screen with the final exam review. Here it is. Hopefully you guys can all see it. Yep. Awesome. All right, so the first thing to note is that it is going to be 100 multiple choice questions, okay? I think that is very doable in our window of time. However, and the reason why I know it's doable is that the bulk of you on the quizzes complete 40 questions in less than 30 minutes, okay? So these, we're going to talk about kind of what the composition is going to be. But there are always a handful of you guys who like to reread and really take your time. Know that you will need to pace yourself. Some of the questions you will likely go through incredibly quickly because they will be pulled directly from past quizzes. So if you study some of the past quizzes, which is the first thing I tell you that you should really do, you should be able to recognize it. So it's not even like spending time thinking about it. You should know what the answer is quickly. That's going to be a great portion of the exam. There is going to be more of a thinking part for the clinical questions, and we'll go over a couple of samples of those so you get a sense. But because they build, again, you're not reading a whole new content. So even those should go pretty quickly. So all in all, I want you guys to be aware of the number of questions and the amount of time you will have. So that'll be something to be mindful of. So what should you study? So start by studying the old quizzes. There's going to be about 30 questions that are pulled directly from the old quizzes. So the best way to do that is take a peek at your Scantron, take a peek at what the questions were. This is all on, you should have your own Scantron, right? That was emailed to you guys. And then on D2L, there's every format of the quiz. Look back, and then if there's anything you're like, oh, I got this wrong, what is the correct answer? What do I need to do? That's the perfect time to go back to the lecture notes, go back to the textbook to try to really figure out like, where did I go wrong on this one? I would not memorize all of those. That's a lot of information to memorize, and I hate memorization. But if you've gone through and read through it and understand the questions when they pop back up on the final exam, it should be pretty straightforward to go through. So that is the first thing that I would recommend because that could easily be 30 questions that you get full credit on, right? So going back, making sure you master this will be important. There's going to be 40 questions on material you've not been tested on yet. And those 40 questions, so imagine if we were just doing a typical quiz, it would be on the chapters that we just covered since the last quiz. So that'll be chapters 16 through 18. So we talked about childhood disorders, disorders of aging, and then mental health and the law. Those 3 PowerPoints, look through those. There's going to be 40 questions just based on that. So those are going to be brand new questions, okay? Again, it's going to be similar in terms of content as a regular quiz, so go through those as well. Okay, and then this is just to kind of guide your time. The information from the first quiz should be studied the least amount, and here's why. Really, this class is about psychopathology, right? And the first few chapters, if you guys can go back in time, we talked about history and we talked about research and we talked about how to assess and some forms of treatment, but it was really intro to treatment. That is kind of beyond, we've scaffolded above that now. So I wouldn't spend a whole lot of time on that. And in fact, the questions that'll be pulled from that quiz will solely be about treatment because that's what's applicable for the remainder of our semester together. So if you're thinking like, how can I maximize my study time? Study quizzes 2 through 4, and then study the chapters 16 through 18 because that'll be the new material. Okay. I'm talking fast. Any questions about that so far? Anything folks are not quite sure about? Make sure that, no? Okay, I'll just keep going. So this is kind of a reiteration of what I just said, but chapters 9 through 15 end up being kind of your meat and potatoes. That's what is going to be the bulk of what we end up studying. And actually, that should say review quiz 2 and 3. I would include 2 through 4. Let me just make a change right here. I don't know why I didn't include 4. Because that definitely, there's going to be stuff from quiz 4. So 2 through 4 is where you really need to be focused on, which that's chapters 9 through 15. As I said, chapters 16 through 18 should also be studied, but there'll be 40 questions, and that will be the brand new material, okay? If we remember kind of the rules of memory, the recency effect is definitely a thing. That's the most recent thing we just covered. Hopefully that is still fresh on your mind and easier to access, in terms of studying and getting prepped for that. The remaining questions, these clinical vignettes, there's going to be 30 of those. And when you're looking at those, and frankly, just even for a specific diagnosis, when I ask you questions, when you're dissecting the question that I'm asking you, make sure that you have a good grasp of this. So I'm looking again, how to most successfully study for this course. I would take a peek at every diagnosis and make sure that you have a good understanding of the following 4 points. What are the key symptoms of the disorder? Like what is most common? Don't find like, oh, 1% get this really weird thing that I'm not going to ask you about that. What is the key symptoms of that disorder? What are the defining features that separate it from another disorder? So, for example, if we're looking at acute stress disorder, what differentiates it from other kind of long-term stress disorder is it's the time, right? Like the period of time. That's what differentiates it from PTSD, for example. So that know those pieces, how they are different from others. Third, are there any potential medication reactions that should be known? We've talked about medication in this class, right? For multiple of the disorders. So if that's something we've talked about in class, like you want to be mindful of a specific medication reaction, make sure you know that, okay? So for example, we've talked about that with bipolar disorder, that if somebody is coming in and they're being given an antidepressant, an SSRI, and it has not been fully assessed whether they've ever had a manic episode, that could trigger a manic episode, right? Or another example would be if somebody is coming in and they're on an antipsychotic like Haldol and they're experiencing all these additional symptoms, what could be the cause of those additional symptoms? Maybe medication related, right? Because we've talked about that. So those are the kinds of examples that I mean specifically about medication reaction, okay? And then lastly, if the symptoms seem like the diagnosis, you're like, this looks like a duck, quacks like a duck, right? What other factors do you need to consider in order to rule out that it could be something else? Okay. So, for example, think about substance abuse. Could somebody being on a substance abuse present symptomatically as a disorder, right? So, you would want to rule out before you pick that diagnosis, you'd want to rule out that substance abuse, right? Or a medical disorder. Could another general medical disorder actually be the root cause of the symptoms? So that would need to also be ruled out prior to going with that full diagnosis. And then other mental health disorder, right? So do we want to actually go down that path? Like we need to rule out that it's not something else. For example, with ADHD, we might need to rule out that it's not anxiety, right? Because it might present similarly before we go down the path of medicating for ADHD, right? So that's what I mean by like, make sure that you know your differentials and how to rule out. Any questions about that? Is that making sense? I can't tell if people are awake, engaged. Just kind of chilling. We good? There's 96 of you on here, so I think, yeah. Okay. All right. Well, there's some participation now. So these are some sample vignettes that I want you guys to think through. So this is how I would present it. Sasha visits her 80-year-old grandpa and notices he seems confused and disoriented. She knows he has a history of depression. Based on this information, which diagnosis is not on your radar as a possible cause of these symptoms? So again, not what could it be, what can you just rule out and toss out and go, no, that's not likely to be it. Okay. And the options are some form of dementia, delirium, substance abuse, bulimia nervosa. So what do we think? We put it in the chat. Olivia, you asked, will there be free responses? No, there will not. The short answer that I meant was, I said that totally inaccurately on the syllabus. I meant multi-part clinical questions. That's, to me, they were short because they were longer together. Anyway, that was not a good way to describe it. So no free response. All multiple choice. Thank you, Joanna. Okay, DD, bulimia. DDD. Woohoo! That is correct. Okay. Why is it we could possibly consider the other three? Let's think critically about this one. Oh, thank you, Jenna, for answering that. I appreciate it. So what about my description in the vignette makes you think it could be some form of dementia, delirium, or substance abuse? If we're ruling out bulimia, explain to me your thinking. And you can speak. You don't have to just type in the chat. TJ, you said age explains dementia. Depression explains option B and C. Oh, Nandini, you need to go back to the PowerPoint on disorders of aging. There's a whole section we did on delirium. History of depression could have used substances to cope. That could lead to disorientation. Good, Haley. Confusion and disorientation aren't usually symptoms of bulimia nervosa. Yep, Izzy, that's correct. Confused and disoriented is symptoms of A through C. Yes. Ooh, I'm going to butcher your name, I think. Thielen? Now I feel like I want you to tell me what your name is. Can you say it in the chat so I know? Or
Hyland.
Thielen?
Hyland.
Hyland. Did I get it?
Yes.
Okay, thank you. Yes, you're absolutely correct. The confusion and disorientation are symptoms for the first three. They are not typical symptoms of bulimia nervosa. Okay, very good. So if we move on, now this is part two. Whoops, I want this to be moved over here. So Sasha decides to call 911 because she is not sure what is going on. The 911 operator asks her how long he has shown this confusion and disorientation. She answers that he was himself 2 days ago when she visited him. Based on this information, which diagnosis is not on your radar as a possible cause to these symptoms? The options are Alzheimer's, delirium, substance abuse, or stroke. What is our thought? What is not on our radar? Okay, we've got a few folks saying A. You guys are gonna kick this final exam's booty. Yes, it is A. Good. Okay, why is it A? Why can we rule out Alzheimer's? Only 2 days. So Madeline said, sorry, the chat moved quickly. Only 2 days, and it's not that quick of an onset. Michaela, you said the time period. Sydney, you said it's not something that just pops up immediately. Alexis, the rest have the possibility of a faster onset of confusion. Yep. Kira, 2 days isn't long enough. Good. Alzheimer's long process from Sarah. Haley, gradual change. Excellent. It's the timing, right? If we know, if I'm including that everything was fine 2 days ago, we can rule out Alzheimer's. It would not be that sudden, right? What we know is it is a progressive disorder and it shows decay. So there is loss of function over time for sure, but it's not going to be from day 1 to day 2, right? It's not going to be that quickly. Whereas all of the other ones, a marked part of those disorders or those diseases is that it is quick. It's something that happens very quickly, right? Delirium, we know that's short term. Substance abuse, that could be again short term, right? You're experiencing the effect. A stroke, again, very short term. So Alzheimer's is the only one that doesn't qualify that way. So even if you were thinking it the other way around and you weren't sure what Alzheimer's was, let's say, you could figure out the correct answer by knowing the other pieces and knowing the timeline. Okay. All right, so here's the third part of the question. Sasha joins her grandpa on the ambulance, and when they get to the hospital, they begin their assessment. What would be an important first assessment? We've got a CAT scan, MRI, blood work, full psychiatric interview. What do we think? Okay, so far everybody's on C with blood work. Okay, why did we pick C? So Natalie, you said blood work to rule out substances. Okay. Same with Haley. What else? I totally just drank too fast and spilled all over myself. Easy to do and quick from TJ. Whoops, sorry, I think I missed some responses. Izzy, you said A question mark? The answer is C, blood work. You guys rocked it. Okay, Sarah, to make sure it isn't a life-threatening stroke, yes, a CAT scan could help with that, but actually blood work would also show indicators. We are missing a major reason why we're doing blood work, though. I mean, you guys are getting to the right answer. That's great. If I'd worded the question slightly differently, you might not. So that's why I want to make sure we flesh that out. So Maya, you said it rules out a lot of stuff. Tell me what it is all ruling out aside from substance use. Or anyone can answer, obviously. Infections. Madeline rocked it, right? So what we know is one of the largest causes of delirium in the elderly is often a urinary tract infection. We talked about that in class, right? So you want to make sure that you can rule that out. So in part, someone else said this earlier, it is quick to do, right? It goes right to the, like, if you think about it, you're trying to assess in the broadest of category first, and then you fine tune. So as you're not finding answer with your broadest assessment, you fine tune, fine tune, fine tune. So with this, blood work would answer a lot. It would tell us about what's going on in terms of is overall cardiac health, right? You could do a cardiac panel in case that a stroke could have been possible. You might be able to see if there's substances if you end up doing that kind of testing. You can figure out if there's an infection if we're looking at your blood cell count, right? All of that answers so much of what we're already possibly thinking that is the best way to go. It's if that shows inconclusive results, then you escalate it, right? Then maybe you go to a CAT scan or MRI or even a full psychiatric interview. But the first thing, the cheapest thing, quickest thing is blood work. Okay, very good. Do we feel good about this kind of question? Hopefully this is helpful in having you guys kind of study like what kind of questions I'll be asking. Okay, let's do one more. Natalie has been struggling with her weight for years. She is now in her late 40s and notices she has gained a fair amount of weight in the last 2 months. She goes to see her doctor to discuss options. Based on this information, which diagnosis is not on your radar as a possible cause of these symptoms? Anorexia nervosa, bulimia, depression, or anxiety? Everybody said A? Any other thoughts? A is not the correct answer. So let's go with our second answer, and then we'll talk about why. If it's not A, what could it be? If it's not B, what could it be? D, yes, anxiety. All right, let's talk about this. Did I say she's overweight in this question? I said she has gained a fair amount of weight. What's a fair amount of weight? I think all of you guys went to a large quantity of weight, right? And in your mind, you likely pictured somebody who was overweight or maybe obese. And so then I'm assuming this is the thinking, then you ruled out anorexia. Is that kind of what you were thinking? Okay. Yes. Okay. What else is a major feature of anorexia? Okay, so underweight. Yep, that's the same thing. Disordered eating. Okay, lot sure. What else? Distress in eating patterns. Okay. Fear of being overweight. Maha, you're getting close here. Small avoided weight is very significant for prolonged. Yes. Body dysmorphia. All of those pieces are massive. Okay. So perception plays a huge role. In this here, I didn't write her doctor is concerned about the significant amount of weight she's gained. That is not how it's written. She is concerned because she has gained what she has determined is a fair amount of weight. Okay. From this, we cannot determine whether that is a distorted belief or a factual piece. And even then, if she was 15% underweight and is now 5% underweight, right, that could be a significant weight gain and still be underweight. So we cannot exclude anorexia from this. Why can we not exclude bulimia? What do we think? Weight fluctuates. Yeah, so that's the biggest piece. Is what we know. If we think back to our lecture on eating disorder, I had like this, clearly I'm obsessed with Venn diagrams, so I'm going to bring it up again. But there's a Venn diagram that talked about kind of underweight, healthy weight, overweight, and obese, right? And where the disorders kind of were overmatched, like or overlapped. Bulimia can show being slightly overweight. So that could be possible that somehow that has shifted. So we can't necessarily, based on this very limited information, because this is very little, we cannot eliminate bulimia. Why can we not eliminate depression? Why can we not eliminate depression? Please, my screen. Depression can cause weight fluctuations as well. Yeah, we know that that's a significant piece, is that it changes your eating patterns, right? And so one of the questions is, have you had a change in weight? And it could be loss of weight or increase in weight. Based on this, we cannot tell. So why is the answer anxiety? You're like, because all the other ones you told us they're wrong. Yes, that's also true. What's the main reason? No idea. Did we talk about anxiety having anything to do with eating and change in eating habits? We talk about worry, intrusive thoughts, rumination, right? Physical symptoms, right? It can, Riley, it can correlate with less eating, not always, right? It often doesn't have a connection to it, right? Like they're not as linked. Um, Anxiety could be a product of this, but not the main cause. Yes. Uh, yeah, anxiety can be part of the disorder, but not the singular reason for weight fluctuation. Correct, right? So right now, that's not what's on my radar. Like I'm not thinking, oh, this looks like anxiety. Okay. Alexis, you're asking, why couldn't it be someone being overly attentive to their body and going to the doctor because of that concern? So that would like almost like an obsessive compulsive, because we know that there's a connection there with that. Yeah, maybe that could be it, but then that would be OCD, right? So that's the direction we would go. Based on this very limited information, we are trying to assess what is the cause of the weight gain it is likely not anxiety, right? Because that is the only symptom that we have provided. So when the question is, based on this information, which diagnosis is not on your radar as a possible cause of the symptoms, anxiety would not be a possible cause, right? It's likely a cause of what's getting her to go see the doctor, right? That you're spot on. Okay, so let's add more info. The doctor begins by explaining to Natalie that her weight falls just above the threshold for healthy weight in the overweight category. Based on this information, which diagnosis is not on your radar as a possible cause of these symptoms? This one should be a little easier. This is how bad I am at getting, I'm like, oh, no. So C is correct. C is correct. Binge eating disorder seems like it might not fit as well. I agree because you would likely be in the overweight to obese category, right? And she's just recently lost weight. But if we go back to the first part, the very first part of the question was, she's been struggling with her weight for years. So it is possible there's been past binge eating disorder and we've just re-entered into a cycle. Okay. That is why binge eating disorder is not the best choice out of these. Anorexia is the best choice out of this because the main part of anorexia is being underweight, right? And now that is not, she's in the overweight category. Okay. Does that make sense? Hopefully this one is a little bit more straightforward. Okay. Next part, before deciding on a course of treatment, what would be most important to assess? Blood work, full psychiatric interview, consult with nutritionists, or ultrasound. Oh, I love questions like these because now it's all over the place. Okay, I feel like I've seen, and it's hard because there's not a comment between the two different questions. So I can't quite tell where it begins and ends, but I saw some A's, B's, and C's. Okay, so no one considered D, it sounds like, just based on looking at that. What made you not consider D? I just want to take it one at a time. Not that D is the right answer, it's not. How did you rule out D? Any thoughts? Based on what's on our radar, an ultrasound wouldn't diagnose those conditions. Only weight gain, so there wouldn't be much reason for an ultrasound. It wouldn't give indicators for most of the disorders you're looking at. I don't know what an ultrasound would really reveal because a lot of possible disorders are mental health related. Okay. What if she was pregnant? Could that account for weight gain? She's been dealing with weight, struggling with her weight for a long time. Yeah. Okay, Alexis, I like that answer a lot. Okay, blood work would reveal that among other things, so ultrasound is unnecessary. Absolutely. That's exactly what my thinking was there. I would want to make sure this woman's not pregnant, right? First off, she late 40s, kind of late, but could still be pregnant, right? That could account for weight gain. And people who've struggled with weight their whole lives, that does not necessarily mean that there's a psychiatric disorder, right? Can we agree on that? Like, I think probably the bulk of the population, we can go down the path of culture and society and what is viewed as beauty, right? Like, so people struggling with their weight, that might be normal, actually. What she's concerned with is a significant increase in the last 2 months. Pregnancy could be a cause for that, okay? But it is not the best answer here because blood work could answer pregnancy along with many other things, okay? Blood work is the correct answer. It rules out pregnancy and something we've not talked about in here yet, could also rule out a medical disorder that could explain away the weight gain, right? Hypothyroidism could be part of it. Maybe she's menopausal, so doing a hormone panel would rule that out. So before we go down the path of diagnosing and slapping a label of a psychological disorder, Haley, I'll answer your question in a second. Before we go down that path, we'd want to make sure that it's not something else that would necessitate a totally different form of treatment, right? Because then once, if let's say nothing is conclusive based on that, then B would be the correct answer. We would want to do a full psychiatric interview. Then, if we saw there's nothing going on that is causing these symptoms in terms of maladaptive thinking, distorted thinking, right? Stress eating, being depressed, all of that, if that's not it, then we go with a nutritionist because it might be some just education that's lacking to make better food choices to reduce the weight gain. Okay, so that would be the order that I would kind of count that out. No, oh, okay, so Hope, we're going to talk about that in just a second. So Haley, blood work, is blood work always the first assessment? Um, no, not always. But these two scenarios involved going to see a medical doctor, right? One was at the hospital and one was going to see her GP or practitioner. So again, they will likely look at it through that lens. We don't jump to a psychiatric disorder right away, especially because if you look back at the front page of the final review, we talk about like, can this be explained by substance use and other mental health disorder or, right, another general medical condition? And in fact, when we went through every single diagnosis, that was always one of the factors. Cannot be explained by another medical disorder or another medical condition. So we want to rule these two out. Not every single question will include something like this, right? Many of them will be with a therapist or a psychologist or a university counseling center, and that's not going to be the way they go. Okay, Hope, you said, why would we have to rule out pregnancy and menopause if it wasn't an option earlier? That seems very broad. So this is part of our job right now, like well, it's definitely part of my job, but for you guys in this class, this is part of thinking critically, okay? This is part of really looking at the entire picture, okay? And deciding what is pathology and what is not pathology. And so it wasn't an option early. I'm going to scooch my screen here, sorry. It wasn't, here we're like doing the detective work. We get a tiny bit of information. What do we consider? What do we rule out? Go a little further, a little bit of information. What do we consider? What do we rule out? Then you get further, right? And so at that point, you're not just limited to those, right? There's no limit. I mean, this is a multiple choice exam, so I'm giving some things, that way, but I can only pick 4 options because that's what the Scantron limits me to. This whole exam could be short answer, like filling out all of your thinking, which that would be a nightmare for everyone involved. It would be too long for you guys, too long for us to grade. So I'm limited to just 4. So don't be just limited. So again, as I'm looking at the question, I'm highlighting what are the key pieces of information. Struggling with weight for years, late 40s, gained a fair amount of weight. Like these are the key pieces. And then based on the options, what is the best fitting answer? Okay. Let's see. What are some of the questions here? Natalie, you said, I thought it seemed too specific for such little information. Whoops, sorry. So blood work would keep it broad to then get more specific over time. Not sure I'm understanding the question. I think, Natalie, I think I'm on the same page as you. So the answer is blood work. That is the answer. So that keeps it broad. And then if that's not discovered, right, then you go down to full psychiatric interview, then you go down to consult with nutritionist. So that would be like, if I think about a funnel, right? So I think we're saying the same thing. Could you zoom in a bit more on the review? Joanna, I'm going to say no to that. You have access to it. So maybe you can open it on a different screen. I mean, I could try, but then people won't see the questions in Zoom. So you guys have access to this, and this is also being recorded. So, oh, yeah, Natalie, I think, yeah, that's your thinking is right. Broad to specific. Okay. So that's the scoop. Those are the 2 examples that you would go through in terms of clinical vignettes. So going back over here, let me make this smaller again so people can see. This is what we're looking at. So when you go through the questions, again, there's going to be 3 that are going to be pulled directly from quizzes 2, 3, and 4, maybe 2 or 3 questions from quiz 1. Okay. So that you should be able to nail those and answer them and maybe even recognize like, oh, I know exactly what she's asking here. Choop, 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 get it done quickly. Then study chapters 16 through 18. That's the brand new information we've covered since the last quiz. 40 questions from that. And then after that, it's going to be these 30 questions, which could be on any diagnosis. So I would focus honestly from 9 until 17. The clinical questions are not going to include anything about mental health law, right? Because that's not really relevant to diagnosing. So it's going to be everything else that has been diagnostic. So think depression, anxiety, trauma related, eating disorder, somatic disorders. What else did we cover? Obviously, disorders of childhood, disorders of aging, psychotic disorders, and personality disorders. So you just need to go through all of that and make sure you've got a handle on that. Alexis, you said when an answer choice says anxiety or depression, are we thinking specifically generalized anxiety disorder, major depressive disorder, or any of the anxiety disorders, any of the depressive disorders? Good question. If I'm saying anxiety, I usually am going to be meaning generalized anxiety. For these clinical questions, again, I'm starting broad. So these are going to be large categories as I'm trying to like rule things out. There's going to be far more specific questions in the non-clinical. Actually, I think at least 2, even in the clinical questions. Why have you decipher between different anxiety disorders? But then it'll be specific. It'll say GAD versus panic, right? So, versus phobia. So then you can definitely tell the difference apart. But if I just use broadly depression or broadly anxiety, I am meaning broadly major depressive disorder, something like that, versus just general anxiety disorder. If it's going to be more specific than that, that's what I'll give you. Good question. Will there be any questions about theories like cognitive behavioral, social cultural? Um, yes-ish. So not the specific theory, like, do you know what the theory is? Hold on, let me grab my water. But more to do with if this this therapist is looking at it through this lens, what are they most likely to do? We've had a number of questions like that on past quizzes. So that would continue something like that. Hopefully that answered your question. For the new material on law and mental health, I know we talked about real cases with certain individuals. Will we need to know specific names and results of the cases themselves? The only one you need to know is about Tarasoff, the last one we covered, because that led to the duty to warn. So you don't necessarily need to know like every single little detail about what happened with the guy who killed her and all of that, but just that there was a case law came into existence with this particular case and changed everything for therapy. I mean, because now our consent form and confidentiality statements have shifted because of that case. So it's a massive case law that you would need to be aware of. But some of the other ones we talked about in class with like the gal who killed her children and was incompetent to stand trial, like you don't need to know her name. You don't need to know the results of that case at all. No, those were just like examples to try to make it a little bit more vivid. Hopefully that helps, Haley. TJS, would you tie in the theories to the clinical multi-part questions? No. Good question. No. The clinical questions are going to be really exactly what I just wrote there, where you're thinking like, here's a tiny bit of information. What are you thinking? And then here's a little bit more information. What are you thinking now? Here's a little bit more information. What are you thinking now? So it could include a client felt this way, went to therapy, saw a psychiatrist, is on this medication, and now feels this way. Why would that, what could explain away the shift, right? That could be in the clinical section because that would tie back to, I wrote that over here under part 7 here, any potential medication reaction, right? So that would answer that portion of it, but not the theories or like therapeutic approach that way. Hopefully that answered your question. Okay, Emily, whoops, Daisy. In terms of the psychotic disorder, do we need to know the other schizophrenia spectrum disorders that were briefly mentioned on a table in the slides, like schizoaffective or just schizophrenia? No, you do need to know all of them. So schizoaffective, we definitely talked about that. We talked about brief psychotic disorder, and schizophreniform is part of that, like within the brief psychotic disorder section. So you need to know the fact that it's a timeline thing, right? That's really what differentiates all of those. And then schizoaffective, that it's mood related. That's about all you need to know for that. So hopefully that helps. Yep. Oh, yep. Fiona, you already answered that question. Great. Is there an estimate for when interview papers will be graded? Will we have the grade back before the final? No. I'm going to say you probably won't. Just being realistic with how many papers there are. So I wouldn't go into it expecting it. If it does happen, huzzah. But yeah, there's a lot of papers and few of us. So we're doing our best. Okay. Any other questions I can help answer? Oh, there's a couple. How should we break up our studying to remember more information between now? I don't know why I can't see oh, there it is. And the time of the exam. I don't think I have a good answer for you, Lauren, on that one. I think it depends on what kind of learner you are. There are some folks who will divide it up like I'm gonna really read through a chapter a day or write notes a chapter a day and let's face it, there's probably some of you that are gonna study Monday night and that's gonna work out just fine for you. I don't know that I have a good strategy for you. The best strategy I can give you is where to put your focus. And that's what I tried to write in this document. Like, don't spend a ton of time on quiz 1. That is not going to be worth it. Spend quite a bit of time on quiz 2, 3, 4 to review the questions, make sure you understood the ones you got wrong and that you know the correct answer. Because again, I am pulling, and when I say I'm pulling questions, I mean literally, I will copy and paste a question that'll be directly on the final exam. So 30 of those to me should just be free points, which I realize that I recognize that doesn't necessarily mean that, but my hope is that it's kind of giving extra points. And then I would really focus on chapters 16 through 18 because 40 questions are going to be brand new from those chapters. I think if you study the quizzes and then study 16 through 18, you will have done a review of everything we covered in class and you should be in good shape for the 30 clinical questions. So let me go back. I think I missed some others. Okay, thank you for Yona for understand. That's a better answer probably. Nandini, you asked, and no numbers again, right? No, never. I don't. That's not helpful. So yep, if you see, in fact, that is a telltale sign. If you see a question and one of the answers has like 25%, you're like, that's Wooltell being crazy. No, we're gonna just knock that out. That is the red herring. Don't pick that, right? I'm not gonna have you remember numbers. No. Quiz 1 and 4 forms aren't available on D2L for me at least. Okay, thank you, Alexis. They're in the announcement tab. Okay. I think all the quizzes are available. So sorry if we put it in a weird format, but okay, great. Did all the quizzes have the same questions? Just yes, Maha. That's correct. Well, no, I'm lying. Quiz 4, I made a major boo-boo on form C, I think, and there were some repeat questions. So if you had form C for quiz 4, this is why I adjusted everybody's quizzes to give extra points because otherwise that wasn't going to be fair. Look over, there's 5 questions that were not on your exam, so make sure that you look at those. But I'm going to tell you right now, I'm not going to pick those for the final exam because that seems rude. I'm not going to do that. Would the polled questions from previous quizzes include the ones that weren't? No. Yeah, I think I just answered that. Yep. I'm not going to do that. That's not nice. Good question, Emily. Any other questions, guys? Just to confirm, the lowest quiz grade will be replaced with the highest ones. The grades we see on D2L right now is in the final grade. Correct. Thank you for bringing that up, Ying. Yep, that is going to get adjusted. That's actually a project I'm hoping to tackle by the end of this week so that you guys go into the final getting, but you can also do the math on it. So whatever the lowest quiz score that you have, replace that with your highest. Yep. Good question.
Can I just say one thing? I feel like in terms of the theories that we've went over in class, I think in terms of reviewing it, just make sure that you're reviewing how to integrate and how to be able to tell in the cases instead of like I'm memorizing the definition, because that's probably what's going to come up in the quizzes. Like asking if you're with a therapist and they're focused on your childhood trauma, then like what would that be in terms of the theory? So like kind of like reviewing the application of theories, that would get you points.
Yes. Very good comment there, Fiona. Absolutely. Again, I'm not huge on memorization. I don't think it's helpful. I want you guys to be able to understand it and apply it. So if you look at the different, theories, and again, I think especially quiz 3, there are a few more applied like theory questions. Make sure that if I say there's a multicultural approach, what does that entail? And then look at the answers that are related to multicultural, right? That also relate to the specific diagnosis. Is SONA still an option for extra credit? Yes, if there's still active studies going on, yep, you can continue to do that. Schizoid and schizotypal, they seem very similar on the slide. They do, actually. They're very similar. Schizoid tends to be far more removed. Like they are not, think of them like they're not seeking interpersonal relationships. They are kind of just really more hermit-like on their own, and can have some bizarre ideation. But again, not schizophrenic, just like odd beliefs. Schizotypal is definitely full-on odd beliefs, not schizophrenic, and they desire relationships. So I think that would be the main defining difference there, is that schizotypal tends to push back people from relating to them because of they're oddly related. They tend to have some more bizarre beliefs, whereas schizoid are not seeking relationships in quite the same way. They're kind of really on their own. That's more the theory of like they think they're inferior to others. They don't want to interact with others. Okay, I think I missed a couple. Hopefully that answered your question. Any specific disorders you can recommend we study more? I know you said quiz 2 to 4, but any of those specific topics? No. All, I guess, would be the best answer. I can't seem to find quizzes 2 and 4 in the D2L. Is there a chance they were emailed? No, they're out there. I think they're in the content sections. Yeah, there, Alexis answered that. They're in the content. Okay, great. Hopefully that answered everybody's question. Okay. Anything else? If you guys have more questions, obviously reach out to the TAs or myself if something comes up. I am gonna post, here, let me stop sharing. I'm gonna post this review also on D2L. Sorry, Haley, I'm seeing your 70 question. I don't know what that means. I'm not figuring out the content of that either. So if you have a specific question, let me know. Yes, Nandini, we said already, so quizzes 2 and 3 and content section 1 and 4 are in the announcements section. Okay. All right, you guys, reach out if you have any other questions and we'll
I
go
have a
next.
question.
Okay, yep.
I emailed you about my Sona hours, and I was just wondering, like, how I submit that for extra credit, or like, I sent you just like a screenshot of it, but I
Yeah.
didn't get a response, so I was just wondering, like, how I do that.
Yeah, so it's because I talked about it in class, Libby. So we are going to get a list of all the students who participated at the end of the semester, and that's when it gets added. So that's what will be done. So I don't need anything
Oh,
from you.
okay.
It's
That
direct.
makes sense.
Yeah, yeah.
Okay,
Okay,
thank you.
no problem. Haley, you just asked, can you explain further the HPA access? Is this something important to focus on? I'm not even quite sure what you're referring to right now. Send us an
Um,
email.
okay.
Yeah.
Yeah, it was the one that kind of talked about like it had to do with like the pituitary gland and like the hypothalamus. It was like the
No,
HPA stood for.
no, that's like, I think back, maybe we talked about it with anxiety, but really think we're just really focused on clinical presentation and diagnosis. Yeah. All right. Any last minute question? Nope. Okay, gang. We'll see you bright and early, 7:45 on Tuesday for the exam. All right. Talk to you guys soon.
Thank you.